All right, it's a great pleasure for me to introduce Stanley Perlman. Stan is a professor of microbiology, immunology, and pediatrics at the University of Iowa. He's an MD, PhD. Stan is a long-term leader of the coronavirus field. He's published over 180 papers on coronaviruses, really a huge contributor to our field, a huge leader in coronavirus research. So we're very fortunate today to have Stan here to tell us about his work. His title is the SARS-CoV-2 epidemic. And so, Stan, thanks very much for coming.
So thank you very much. It was great fun listening to Susan. Susan and I, as she may have told you, know each other for almost 50 years. We met when she was 2 years old, of course, and I was much older. But we have done things together for a long, long time. She was the first person to give me my first vial of mouse hepatitis virus. So we've been doing this a long time. And for so many years, we were in the backwaters of coronavirology, as it was described in 2003. And after this pandemic, I wouldn't mind going back to the backwaters of virology because this is such a devastating disease. So I have no conflicts of interest. So the goals of this talk, I'm going to be doing less of the molecular description than Susan did. I'm going to be more talking about the pandemic itself. There's a lot of things we've learned. It's been amazing for me. I think I used to pride myself on being able to keep up with the coronavirus literature, and I think that there must be, I don't know, about 40 or 50 papers a day now, to say nothing of the ones that are on bioRxiv. So it's really a challenge. I get called about questions that I didn't even know existed because a paper came out just in the last 5 minutes. So the goal of this talk is to talk a little bit about human zoonotic and potential pandemic coronaviruses. Some of this will be redundant with what Susan said, but it may have a little different spin on it. I'm going to go over some frequently asked questions, some fakes and facts, and talk about the SARS-CoV-2 infection. I know Susan's done that already, and something about replication, antiviral strategies, and vaccines, and then there'll be time for questions. So some of the frequently asked questions are, what about pediatric disease? Why do children get less severe disease? We certainly know that children do not get zero disease because every now and then we hear the sad event that a child has died from this infection, but it certainly is a disease of the aged more than of children. Influenza causes more illness and death, so why do we care about COVID-19? This question is a little old, and it's become very clear what the answer is. The mortality rate is low. What is the big deal? Can the virus spread asymptomatically? This has become a huge deal in the last few days, and I'll try to address it. How is the virus transmitted? Why is it so hard to control? And Susan talked about that a little bit. And immunity to other coronaviruses. Is this protective, irrelevant, or detrimental? And they say the coronavirus, is there only one? I think for this audience, the answer is obvious. Was the cruise ship quarantine a good idea? I think we know the answer to that. That was a really bad idea. But why did SARS disappear, and is this virus pandemic? How long will a vaccine take? Do we have any drugs to treat this? Should I not take NSAIDs like ibuprofen, aspirin? Should I stop taking my antihypertensive drugs? So those are some of the things that I'll try to cover in the next bit of time. So coronaviruses, as Susan mentioned, are global zoonotic threats. We know that 1,000 years ago, the coronaviruses 229E and NL63, which are cold coronaviruses, appeared in human populations, and they diverged from the same ancestor, which was likely a bat. One of the things we would be really curious about is to know whether these viruses, when they entered human populations, also caused severe disease for a while before changing into viruses that cause the common cold. Because this is what viruses like to do. Viruses usually like to attenuate because otherwise they kill their host and they don't have a place to replicate. So it's the goal of the virus is to make more viruses. OC43 infected humans 120 years ago or so. This is based on molecular time clocks. And this virus probably crossed over from cows. There's some argument that we gave the virus to cows, but I think the argument is stronger that it's from cows. And then cows have spread it to other animals that are other similar ruminants. SARS-CoV entered human populations 16 or 17 years ago, and MERS was 8 years ago. This slide is out of date. And both of those viruses are bat viruses, as I believe Susan said. They evolve differently. And just like for SARS-CoV-2, we're sure it's a bat virus, but we don't really know exactly which bat virus because we haven't isolated it yet. MERS is even more curious because and I'll talk about this just for a couple of minutes, it's really a bat virus that lives in camels. And there's some curiosities about how it went from bats to camels. We don't really know that, but then how camels to people is more interesting. So one of the reasons I became interested in coronaviruses, and this is my only mouse coronavirus slide, is what's shown in this panel. So what you can see in the middle panel here is that if you take an animal and you infect it with mouse hepatitis virus, which is very similar, almost identical to the virus that Susan used, and you put it into an animal that has no immune response, what you see here on the left panel under LFB and the middle panel here is that the myelin actually looks normal, and below it is an animal where there's nothing going on. It's a normal mouse. But then if you look for viral antigen in these animals, no T cells, there's tons of viral antigen, and this is actually almost like a perfect marker for oligodendrocytes. And there's a little bit of inflammatory cell infiltrate that's shown here for macrophages, and the axons underneath are completely normal. But this is the thing that I've been intrigued about since I started working with this virus so many years ago, is if you then add back T cells, you get demyelination. The myelin is quickly destroyed. This is only 7 days after adding back T cells to this animal here. Not the same animal, but a parallel animal. Macrophages come in huge numbers, virus is cleared, and the axons underneath are partially destroyed. So this theme of immunopathogenesis is, I think, one that's true for the respiratory coronaviruses too. I think our best data so far from the SARS epidemic, where virus titers seem to be decreasing when people got sicker. So, and that's what's going on here. These mice in the middle panel are perfectly fine. They have tons of virus, but they don't care at that point. And if you add back the immune response here, T cells, you start clearing the virus, and that's when you get disease. And in terms of SARS, MERS, and SARS-CoV-2, though I know less about the last one, it seems that the same thing is occurring. Virus is being cleared. That's when people get sick. And that's why, as I'll discuss a little later, one of the key goals may be to figure out how to clear the virus and at the same time tone down the host immune response so you don't get this equivalent of what we're seeing in a mouse. So the endemic human coronaviruses are 229E, HKU1, NL63, and OC43. Two of these, HKU1 and NL63, were discovered after SARS, and I don't remember if Susan mentioned that. They cause up to 15 to 30% of human colds. There's no durable immunity. This was really shown in the 1960s when several volunteer studies were done with 229E and to a lesser extent with OC43. 229E is believed to be pretty much the same everywhere in the world and all the time. OC43 has a better, more of a tendency to change. So these studies a lot of them were done with 229E. They could take volunteers, show that they had 229E antibodies, infect them with the virus, and they got a cold. And so the level of antibody mattered. If it was lower amounts, they were more likely to get a cold. If they had really high amounts, they were less likely to get a cold. But the key point here is that immunity was not durable. And I think there's one study that showed this occurred even after a year after the first colds, but I'm having trouble finding that paper, so maybe I made it up. But the point is that you can certainly get reinfected in the presence of antibody. Is this relevant for SARS-CoV-2? Perhaps. And upper respiratory tract infections are most common. We know that occasionally OC43 and 229E particularly have been shown to, particularly in the elderly and in nursing homes, have been shown to cause almost an outbreak within individual nursing homes. Again, a common theme that we're hearing now about SARS-CoV-2, where the elderly people in nursing homes are particularly susceptible, and we're hearing about outbreaks across the country in nursing homes. And then also in immunocompromised patients. And there's no vaccines or antivirals licensed for these common coronaviruses. So emerging coronaviruses, we certainly have heard about SARS-CoV-2 already. This is an interesting disease. There's 8,000 cases with a 10% mortality. The virus spread almost certainly from bats, and this all occurred in Guangzhou province, in Guangdong province in China, and the bat virus hopped over to civet cats, raccoon dogs, and then to humans. If you look at some of these critters, this is a palm civet cat. I didn't know anything about palm civet cats until 2003, and palm civet cat is not a cat. The raccoon dog actually is a dog, and the Chinese ferret badger, which is the one I don't show here, is actually not a badger. So, but these are the ones that are mainly involved. The other thing about SARS is that there were 8,000 cases, 10% death, bad disease. But at the time, 8,000 cases was equivalent to about 12 to 16 hours of new HIV cases. So this was certainly a big deal. Asia was, specifically East Asia, was shut down. Toronto was shut down because they had one case that led to an outbreak there. But the big thing we learned is that fear played a major role. And why did we care? Why were people more fearful of this than of HIV? Well, of course, it's because you could get on an airplane next to somebody who was coughing, and you, in theory, could get this disease. And with a 10% mortality, it's not something you wanted to play around with. Then the other disease, which I'll talk just a little bit about too, is MERS. This is really a really slow disease. There's been 2,500 cases or so since 2012. Comes out to about 2 cases a week. Has 35% mortality, and it's in 27 countries. This virus is one that's one from bats to humans via camels, as I mentioned before. And I'll discuss that a little bit more. Here you can see I put down this information about SARS-CoV-2. I think I must have done this, I don't know, like 3 weeks ago, and it's so out of date because there's way more than 75,000 cases in 29 countries. So this disease, the SARS, arose in Guangdong province in China, and again, a common story with SARS-CoV-2, wet markets or live animal markets, may be a better way to call it, were critical to the spread. And at the time this occurred, I'm not sure of all the timing here, but at the time this was occurring, it was illegal to sell these live exotic animals in the markets. And this we know from studies that were done subsequently by several investigators from Hong Kong and China, that the bats contain these viruses, and then it spread, as I mentioned earlier, to these other exotic animals and then to people. And one of the things that was striking about SARS coronavirus is there was evidence that the virus was in humans, that it evolved to better infect humans. So earlier I mentioned that viruses really don't like to kill people because it's bad for their existence, but this virus adapted to people to better infect them. And it was never a very transmittable virus. If you look back at the way it was transmitted, it was really, the transmission occurred, as Susan mentioned, when people were already sick. And so it was easy to identify, and that's why quarantining works so well. The other thing was that there's a factor called an R0, which I'll talk about in a minute or two, which is a measure of how much virus spreads from person to person. The R0 for this is considered to be 2 or 3, but in fact it's a mixture of R0s. The majority of R0 is probably less than 1, but there are people who are involved in super spreading events, so they infected a lot of other people. Probably even more significant was in hospitals, aerosolized procedures. It generated a virus that could then easily spread to healthcare workers who were in that vicinity. That's why we've become more and more stringent and knowledgeable about the kind of precautions that you have to take in a hospital. And as I'll talk about in a few minutes, aerosolization is something that's being discussed again, but not just in hospitals. The other thing that was interesting about this virus is the virus actually crossed many times, we think, from the wet markets to people who were the handlers in that wet market. And most of the time, the virus didn't go very far because it really wasn't adapted to humans. And then there were, I think, a few episodes where it actually adapted and ended up going to various places in China. And that's why the major part of the epidemic burden was in China. Now, the reason the rest of the world became infected was actually because of a single event, which is somebody who was one of the animal handlers in the market became ill. He went to see his physician, and his physician became infected. And his physician was highly susceptible, may have been involved in super spreading events. And what he did is, though, instead of going home and being sick, he decided he needed to go to his nephew's wedding in Hong Kong. So he went to his nephew's wedding in Hong Kong, and he became very ill there. And in fact, it ended up infecting a lot of people on the floor, who then went back to their home countries and infected other countries around Vietnam and others, and other countries around the world. So the Middle East respiratory syndrome was first documented in April 2012. The total number of cases, as I mentioned, is around 2,500. The mortality is 35%, and the majority are so far male. And this is a theme that is also true for SARS-CoV-2 and SARS, and I will try to talk about that later on. The average age, or the median age, was 49, and now, as I said before, there's about 2 cases a week, nearly all in Saudi Arabia. And the infection ranges from asymptomatic to lethal. And this is a curious infection because, well, there's 2 things. One thing I should say now is after watching SARS-CoV-2 become epidemic and are not being that well prepared for it, I think there's an argument could be made for thinking about this disease, which has not really spread much beyond the Middle East. And I'll go over that in a minute. But we don't really have any tools for handling it either. We don't have any vaccines. There's a couple that have gone through phase 1 trials. We don't have any antivirals other than what we have for SARS-CoV-2. And this kind of disease, or this kind of virus, which is trickling along at low levels, it does make one think after SARS-CoV-2 and COVID-19 that maybe we better pay more attention to it and start developing therapeutics and other ways of thinking about this virus. The other thing that's curious here is that there's a mortality of 35%. And from our work and work of others, there's lots of people who have mild disease and lose their antibody titers pretty quickly, or asymptomatic and never develop an antibody titer. So I always thought, and I still think, that the 35% mortality is probably an overestimate because I think the denominator is wrong. But what's curious is that in Korea, where there was a single case, a single person came into Korea with MERS-CoV-2, MERS-CoV, sorry. No COVID-2 yet. With MERS, I think the story is well known. He was ill. He went to emergency rooms in Korea. They didn't ask him about if he had been in the Middle East, and he didn't share that information. And there ended up being an epidemic of outbreak of 186 patients becoming ill. Well, what Korea did is just what they did now during the COVID-19 epidemic. They've gone and done widespread serology. But I would have expected them to identify lots of patients who had mild disease, so their denominator would be big, and that 186 would be divided by a large number. In fact, the mortality only went down to 20%. So I don't understand this because I think there's many more asymptomatic people infected with the virus, but it's very hard to determine who they are. And the same thing may be true with COVID-19. And one of the other things that's important that as I mentioned already, the MERS-CoV antibody response is transitory. So it makes epidemiology studies challenging. And there's other issues with it, which I'll mention as well. So the virus initially, because this virus is not very contagious right now, the R's are not for most human-to-human transmission is about 0.35, which means it'll be extinguished very quickly. But in the hospital, it is up to 5 or 6. And this is where most of the epidemic occurred. It was in hospitals and the virus spreading from person to person within hospital with poor infection control. A lot of the people working in Saudi hospitals, which is where most of the cases were, are people who are not well trained in terms of infection control. The much better procedures have been introduced now. So now at least 50% of cases are primary, so they're not for interhuman contact. But we don't really know where they come from. And as a common theme here, most severe cases are in patients with comorbidities, including diabetes, chronic lung disease, renal failure. This is, again, a common theme that we're seeing with COVID-19. COVID-19 certainly infects and causes the death of people who have none of these, but people who have comorbidities or age seem to have the greatest risk of this disease. So this is one really curious thing about MERS that has puzzled me and many others in the field for a while. So camels are all over the Middle East and Africa, and even as far east as Pakistan. And the serology must be maybe 70 or 90% of camels are positive. Yet MERS is only found in Saudi Arabia. So why is it that this virus is a camel virus that has been found in Saudi Arabia? It's been found in camels at least since 1983 here in Somalia and the Sudan. or probably even earlier. This is just the earliest state that was tested. And yet we can only see disease in Saudi Arabia. So this is a mystery. And then the other thing is this virus didn't cross over from camels to people until 2012, and now it has no trouble doing it about twice a week. So why did it wait till 2012? What's changed? The camels, these camels are all the same species of camels, and we know from recent studies that the camels are imported into Saudi Arabia, but the camels that are in Saudi Arabia don't mingle with the camels that were originally in Saudi Arabia, because the ones in Saudi Arabia were more on farms that they're either pets or used for milk, while the ones coming in are often used for food. So there doesn't seem to be much mixing of the viruses between the two, and only people in Saudi Arabia get infected. So it's very curious. So and then wide-scale serology studies have been done, and they estimate that 0.15% of people in Saudi Arabia are positive for the MERS coronavirus. Again, this number is really hard to know if it's right, because the antibody testing is not very sensitive. I think it's very specific, but it's not very sensitive, so there may be many more. But we're also, given the rate of positivity now that we still think is, in terms of mortality, this number is inconsistent with that. We know camel shepherds are higher, 2 to 2.3%, while workers were 3.6%. And we've done work with this, which I'll show just in a minute before I get on to COVID-19. Because I think that the reason I'm spending all this time in the previous coronaviruses is I think we can learn a lot of information about some of the problems that we may have in detecting the virus, dealing with the virus, and some of the issues in pathogenesis that may help us better handle this pandemic that's going on. So I already mentioned some of this. How prevalent is the infection is one of the things that I didn't mention too much. Is the virus becoming more virulent or readily transmissible? And the answer seems to be absolutely not. Just as Susan described for COVID-19, RNA viruses like to mutate. They're quasi-species, so that they have lots and lots of different viruses within a single person or a single organ in a person. But when you look at the total population, there's no changes that we can detect or make any sense of. And every now and then, because of all the sequencing that's done, we find a virus that, yes, is changed and it should transmit better between people, or it should be more virulent. And then we look the next week and it's gone. So it never has been selected for. And in fact, one of the best illustration of this, I think, or the most curious one, is in Korea. So there we had a single virus outbreak introduced in the population, and we could follow the virus evolution from that one outbreak. And what we found is people have published, and we're doing the same thing a little differently. The virus that's propagated in Korea initially was the same one as in Saudi Arabia, but it evolved so that its S protein now bound less well to its receptor. Not exactly what one would think. And we find that when we put this Korean S protein on the surface of an ordinary MERS coronavirus, the coronavirus is less virulent. So this virus seemed to have no trouble in Korea transmitting from person to person and causing bad disease. But when we look at it more closely, it seems like it's attenuating. So this is something that I think we need to follow and we're curious about. This doesn't happen in Saudi Arabia because most of the cases now are introduced from camels directly. So there's not a chance for human evolution to occur. It's whatever evolution occurs in camels. And this virus has caused a cold very successfully in camels for at least 40 years and probably longer. The other thing that's curious is that the accessory proteins in MERS seem to be deleted without causing much change in virulence. Susan talked about how these accessory proteins are often anti-immune function. I think it's just a little unclear to me exactly which species these genes are most important in. It may be that they're important in the bat more than people. Certainly in the case of MERS, they can almost all be deleted without causing any apparent loss of virulence. There's also curiosities. One of them, OR5 in MERS, is one that is deleted often in mice and in tissue culture cells, yet in humans it's almost never deleted. Well, all the others are not deleted in tissue culture cells, but are deleted in humans and camels. So there's still a lot to learn here. And so what do we know about protective immune responses in coronavirus infections? As I mentioned before, in terms of the community-acquired coronaviruses, protection is waning. Antibodies waning and protection is transient. That's why we get colds over and over again. in addition to the fact, of course, that rhinovirus has many, many species. You can be infected with lots of different viruses that are not neutralized, don't induce antibodies that neutralize against the second one. We know something about vaccines against coronaviruses. These have been tried for many years against domestic and companion animals. Some of the stories about all of these, the ones against a chicken virus, infectious bronchitis virus, causes some protection, but it's a live attenuated virus, gets out into the wild, and then ends up recombining with other vaccine viruses, and you end up with new strains of IPV, which are a problem. They're not all attenuated. In terms of my state and pig, there's a lot of pig diarrhea in this state for baby pigs, and one of the main causes when I first started working on this was on coronavirus, was transmissible gastroenteritis virus. This disease affects baby pigs, and but it's disappeared. Vaccines were developed; they didn't really work so well. But then many years ago, Nature decided that he or she would take a role in this, and a virus called porcine respiratory virus evolved. Now, this was a live attenuated virus. It turned out it no longer caused a gut infection, so there was no enteritis, but it still infected the lungs, and it turned out to be a great virus for now eliminating TGEV from populations. So, in fact, our colleagues who study TGEV no longer study them because there's no funding for this. This is not a disease. There's many other viruses that have since invaded pigs, such as porcine epidemic virus, and of course the one that's not a coronavirus, swine African fever virus, which is a disaster. So this natural virus, this porcine respiratory virus, induced antibody and T cell responses. So, and that's, I think, one of the themes that I think about for vaccines, that you need to have both antibody and T cell responses. A lot of the vaccine efforts now are just aiming at antibody responses. And I mentioned that already. And also the other thing, of course, is this whole issue now of passively delivered antibodies. Are they protected? When are they protective? Could they cause immunopathological disease? What's the best way to use them? Should they be used? I'll talk a little bit about that. So this is one of the studies for MERS that I did with my colleagues in Saudi Arabia. We took just 9 patients who had MERS, and we had PCR positivity, and we knew and they're not very high in this particular study. Then we had serology from these people, and what you can see is that 4 of these individuals never even developed any antibody response. 3 of them had pneumonia, developed an antibody response that was gone within 18 months. And 2 of them had more severe pneumonia, and there you could detect an antibody response for at 18 months. So this is a theme of what we see in all of our studies. Severe pneumonia, more likely you're going to have an immune response that you can detect later. Mild disease or even pneumonia without requiring ICU care, you could get an antibody response, but it may wane. And this is a really important issue, I think, to consider as we talk about vaccines for COVID-19. If COVID-19 is going to turn into a cold in 3 years, that's fine, then it doesn't matter. But if we're going to be exposed to this every year or every 2 years, then we'd like to know that a vaccine actually had long-term protection. So this is one of the things I thought was really curious. This is a study, again, I did it with our friends, my colleagues in Saudi Arabia. These are the black circles and black square, 2 patients in the ICU. We did serial antibody titers and measured neutralizing antibody titers on the left. And you can see the titers are up to 8,000, extremely high for this virus. 2 years later, when we look at survivors, which are not, these 2 are not in this group, you can see the antibody titers are extremely low, showing again that even in the ICU, huge antibody titers appear, they're not protective, and then later on they wane very quickly. You can see even here by week 16 or 17, it's almost down to the same levels that we see in survivors. So the other thing we've worked on is T cell responses, and these are important. We showed these are important in mice for clearance, and that's one of the reasons that I'm so keen on them, even in COVID-19. This has been shown both in MERS and SARS and murine coronaviruses. T cells can be detected at least 11 years after the SARS epidemic ended. Antibody responses were initially said to be disappeared about the 6 or 8 year mark in SARS survivors. We've gone back and looked at that, but we can actually now detect antibody responses in some SARS survivors, not all of them. Okay, so I'm going to go quickly through this because I want to get to the COVID-19 part. This just shows that what we found is that patients who were most sick, they developed the strongest antibody response and CD4 T cell response, but not CD8 T cell responses. So we think that either the CD8 T cell response was very protective in this case, so that they wasn't a chance to develop very strong antibody response, or some other version of this. We think antibodies developed because there was longer time for antigen presentation on cells. Let me just skip that. So the next thing I just want to very briefly, because again I think it's going to be relevant, is that we were interested in these two people a week who become infected with MERS, who they appear in the hospital, they have no contact with camels. How do they get infected? So what we've been thinking about for a couple of years is that this was because they were transmitted from camel workers who have mild or no clinical disease. So we obtained samples from camel workers and measured serology. And what we found is that 16 of 30 were previously infected by MERS, as measured by neutralizing antibody titers, and some additional ones had T cell responses. So 20 of 30 were not seropositive, but immune positive. So the notion that, so camel workers were walking around, developed antibody responses, never had any clinical illness, and they don't have any comorbidities. What we were curious about is whether these people could then spread it to contacts at other places. Again, this is reminiscent of what we're talking about now with COVID-19, of people who seem to be completely well, spreading the virus to others. So we did some work with these workers, these camel worker contacts, either store owners, restaurant owners, and we found that of 75 contacts, 6 were ELISA positive, but 22 are positive for neutralizing antibody, which is one of the things I'm hoping we don't have the same problem with SARS-CoV-2. But that is with the commercial ELISA kit being less sensitive than the neutralizing titers, so therefore missing a lot of individuals. There's many more people working on serology now, so maybe there's better tests out there. And then we took one more step and went to the barbers, because the camel worker contacts all went to the barbers and not necessarily the camel workers. Anyway, some of those are positive as well. In fact, we found 22 out of 34 were positive. We haven't published any of this because this seems so inordinately high. We're trying to confirm it by other methodologies. So this is what we think happens. Camels infect these workers who go get their hair cut or go to grocery stores, and then they interact with the patients with comorbidities, and some of those develop clinical MERS and appear in the emergency room. This is certainly not proven. We've never found virus in all these individuals, which is really the way you want to transmit it. So getting on to COVID-19, this is a disease that, well, this is wrong. Oh, yes, April 2nd, I have this backwards. April 2nd, as of yesterday, there were 1,002,159 patients in the world. There's now more than that. And deaths were 51,485. Which comes out about 4.8%. We all think this is a high estimate because we think there's a lot of people who are in the denominator who have mild disease that we're not detecting. But this number is very stubborn. Just like that number for MERS, it doesn't seem to be decreasing yet. But hopefully as we get better and better, more and more testing, it will decrease. This shows the initial outbreak. So this is the market where the first cases were discovered. This is where the train station was. And this also shows one of the reasons that this virus probably is spreading, not the only reason, because we certainly think that upper airway transmission is really the main cause. But you can see here there's much more air transport leaving China than there was in 2003. You can see with 2003, this has gone up at least a factor of 7 or 8. So a huge increase in air travel, and this has contributed to the spread around the world. The world is so much more interconnected now. And this shows the history of this disease. It probably actually began before December 19th, probably began first cases in November. The very first case that was studied didn't even have contact with the market, Hunan market, that we think is where the infection began. The market was actually closed on January 1st, and then you can see the timeline, first fatal case 10 days later, and the sequence, I don't know if that's here. Yeah, the whole genome sequence was the 12th of January. I think it was known actually earlier in January because people in China were intensively working with this already. And then on January 24th, there were 835 cases, and here we are now at over 1 million. And in the U.S., there's 240,000 cases as of yesterday and almost 6,000 deaths. This is the countries that have the most COVID-19. This is from 4 days ago. And this hasn't changed. You can see the contrast between this and the earlier slide where I said there were 29 countries. Now every country basically has the infection, and if they don't have the infection, it means they haven't tested for it yet, because it's certain to be worldwide and everywhere. And in the U.S., I think everybody has seen this map, that this disease is really centered now in the U.S. It started in Washington, but California and Washington still have lots of cases, but they're less controlled better than in New York, where cases are still increasing, and everybody knows about the terrible economic and personal problems that are going on there as there's a shortage of healthcare workers and equipment. So this is something I mentioned earlier, the basic reproduction number. So this is the expected number of secondary cases generated by a single infected person. The R0 for measles is 12 to 18. For seasonal flu, it's 1.3. For coronaviruses, in SARS-CoV-2, it's estimated to be about 2 to 3. For MERS, it's 0 to 4, but it's really 0.3. The 4 is in the hospital. And the same thing's true for SARS. It's estimated 2 to 4, but that's biased by the transmission that occurred in hospital settings. And for other coronaviruses, the one that cause upper respiratory tract infections, it's nearer to 1 to 2. And one of the things we don't know here, so we know that MERS is present all year round. It seems to be greater when baby camels are birthing, but not seasonal differences. SARS-CoV ended because of the quarantining and effective identification of patients, and that hasn't really occurred since 2004. That's over here. This one here, one of the key questions that were asked, is this going to go away when it gets warmer? Respiratory viruses often do in temperate areas. We don't really know what this one's going to do. Certainly the virus itself, even though viruses really like dry, low humidity, these kind of viruses like dry, low humidity and low temperatures, certainly this virus does not seem to have any trouble propagating now in Singapore or Hong Kong or southern China, where the temperatures are quite warm. And the other coronaviruses are usually in the spring, winter, but they do transmit all year round. So what do we know so far? We know that bats are the ultimate source. We don't know what the intermediate host is, but we think there is one. Mode of transmission, I would have said a month ago that this was primarily droplet and contact, and I still say that. But we don't know right now about aerosolization. There seems to be so much asymptomatic spread where people are just generating virus by talking. So it makes one wonder about aerosolization, which of course will change the way we can manage the outbreak or the pandemic, because it'd be harder to identify people and sequester them if they're really perfectly fine and generated by talking. Fomites are an issue, but again, just like with aerosolization, there's really very little direct evidence that these actually occur as methods of transmission. And then the other one that's come up recently is what's found in the stool. Is infectious virus found in the stool? That's not been clear. When I talk to my friends in China, they tell me infectious virus has been found in the stool. Certainly RT-PCR products can be found in the stool. The incubation period is generally about 5 days. It can be 2 to 14 days. Transmission is everywhere. And the period of communicability is 14 days. This is still a work in progress, figuring this out exactly. And the same thing with the R0 factor. We're not really, we don't know it for sure. It's certainly more than one. And this I already covered a bit, that most of the spread is via respiratory droplets, so that if you stay 6 feet away from somebody with SARS-CoV-2, you should be protected for the most part. If it turns out that aerosolization from talking is a problem, then this, of course, has to be changed. When this first started, we were recommending 3 feet because that's the number that's usually used for respiratory infection. 6 feet is the number that was originally designated for smallpox, so a more contagious disease. I mentioned the stool, but SARS-CoV-2 has also been found in the urine, but the clinical significance is unknown. So routine environmental cleaning and disinfection is appropriate. And in fact, in places like nursing homes, it's just being done all the time, like once an hour. because it's so important that the age to a most susceptible don't become ill. So this is one of the first cases of asymptomatic and spread. This is a letter that appeared 2 months ago now in the New England Journal of Medicine. Somebody visited, someone from China was in Germany at a meeting. She left, people became ill. She then was tested positive. Turned out that looking back, that she actually was sick when she was in Germany. So this was not asymptomatic spread, and this was retracted. However, more recently, there's too many people who are infected with what appeared to be either during the early phases of the infected, the prodromal phase, or even asymptomatic. And we don't really know that much yet about this method of spread. Are these people contagious? I would have said before all this that you needed to, that talking itself wouldn't spread the virus, but that may be wrong. So I would have thought that standing 1 to 2 meters away from someone should minimize the likelihood of infection, even if it's aerosolized, but that probably isn't correct either, because aerosols can stay in the air for longer periods of time. I mentioned that already. So the case fatality, and globally it's 5%, China it's 4%, in the US it's 2.42%, but the US, of course, is picking up many more cases. So this may change, hopefully it changes to be a lower fatality rate, but we don't really know. And the only point to this is to point out that the number of cases, this is a study from a month and a half ago, that shows that the majority of the cases are actually in people who are under 60 years old, that the percentage of people who are older is not very high. But when you look at mortality, that's where you see the huge difference. So almost 15% of people who are over 80 die from the infection. And this is a common finding. 70 to 79 is partway there, but over 85 or over 80 really has a high mortality, between 1 in 5 and 1 in 7 people dying. This, of course, is one of the things that we try to share when we talk to younger people who think, well, look at me, I'm just in either 0 to 9, no mortality, which isn't quite accurate anymore, or 0.2% mortality. But these people, not only do they have a mortality that's not insignificant, 0.2%, but they also can go home to grandma or their parents and make them ill, and those people have a much higher chance coming to the infection. So this is the same thing from just a few weeks ago in the U.S. showing that over 85, the numbers are 10 to 27% mortality, and as I said, I would think the real number is near to 15%. This is something that was recognized early on, that 81% of people had mild symptoms, 14% had severe symptoms, and 5% were critically ill. One of the things that I think is curious is thinking about these numbers. And this is from a while ago, so this is not recent, but these numbers are the same. One of the things to think about, so SARS and MERS had mortality of 10% or 35%. If you then take this SARS-CoV-2 and you take 15% as your denominator instead of 100%, so taking the people who have severe disease, and if you then divide that by about the 3% who seem to die from the infection, you end up with a 20% mortality for those who get a pneumonia that's similar to MERS or SARS, and they in some sense have almost the same mortality as the people who had those infections. So even though the total is 3%, it's partly because there's so many people who have mild disease. And as we keep thinking there's going to be more asymptomatic people, those numbers may change. But if people with severe disease, it has almost the same mortality as SARS or MERS. And these are some of the presenting signs. I won't go over them. The two things, fever and cough, are considered the most important markers, but you can see they're not in everybody. So because of this, some patients now are coming in without fever or cough. We're hearing about people who've lost their sense of smell, have anosmia, and they seem to be SARS-CoV-2 positive as well. And a lot of them just remain asymptomatic. So there's still a lot to learn about who is actually infected with this virus and what the manifestations are. So we need two things. We need antivirals in the short term and vaccines in the long term. So what we want to, and given especially with MERS still lurking in the Middle East, what we'd like to do is we'd like to have agents that may work against all coronaviruses. There's some agents that will be useful now. They may be specific for SARS-CoV-2, but we'd like to have something that will go across all species. Antibodies will be great and vaccines will be great for SARS-CoV-2, but they may not neutralize future zoonotic coronaviruses. So if we had good drugs, that would be a big help. And the goal would be to develop ones that are broadly active against coronaviruses, have a high barrier to resistance, and would decrease transmission, and could be orally administered. That would really be great, because then you could give it to people coming in with mild disease who are in high-risk groups. So I'm just going to briefly discuss the same thing that Susan mentioned, which is remdesivir. These are the polymerases of SARS-CoV and poliovirus and dengue. What you can see is they all have very similar structural patterns. And there's one drug that's being used, remdesivir, which I think has the best chance of actually being successful. We know from animal studies that resistance results in loss of fitness, and resistance results in attenuation. Now, the problem with this drug, and I think it would be really great, is it has to be given early in the early stages of infection. Another paper just came out in the last few days showing that if it's given to macaques that have were infected with MERS, they in fact the drug was a big help if it was given either at the time of inoculation of the virus or within 12 hours, but not later. And this, I think, is a common theme. What we do in this country, remdesivir is given generally to people who are on ventilators already. So the prediction would be that it won't be really very helpful. It may be a great drug, but we may be using it wrong, because we expect those people will probably, that most of their illness by the time they get really sick is caused by the host immune response. Combining remdesivir given early. So an ideal thing would be to take people who come in, have mild illness, give them all an oral drug. Remdesivir is not oral. And the people who didn't respond to that appropriately, then you could you might hospitalize them. And if you knew that their virus was cleared, then you could do something to decrease the immune response so they actually do better clinically. So having a biomarker would also be great. That's another thing that we don't have. Maybe something like IL-6 in the blood. I have no evidence that that's a good marker, but that kind of thing. So you could divide people into those who might need therapy and those who would not. The other thing is that remdesivir was used in Ebola, and it wasn't as useful as antibody cocktails, so it was actually no longer studied. And so this I already mentioned, that host-directed therapy to monitor, to diminish the immune response might be helpful. And there's questions about whether to use NSAIDs. And this slide, this sentence is wrong. It should say acetaminophen and not NSAIDs are recommended by WHO, but there's no evidence that NSAIDs actually cause worse disease. And the other thing that I should mention is that people all talk about hypertensive medicines. In theory, this could increase the amount of ACE2 on surface of cells of the specific kinds of hypertensive medicines. This could make things worse. On the other hand, ACE2 may be anti-inflammatory, so may help the lung recover. So it's really unclear what the effects of hypertensive medicines are. We know hypertension is a risk factor, but we don't know if that's with therapy or without therapy. And at this point, the recommendation would be not to stop antihypertensive drugs. So I think I'm going to skip over well, I'll just mention briefly. So this is the thing that we're trying to do now. I think everybody knows about this, which is to delay the peak of virus, maximum peak of virus replication or spread to people. We know that if everybody got infected at the same time, we'd have herd immunity very quickly, but we'd also have a huge number of deaths, and we'd also have overwhelming of the healthcare system, which is kind of what's happened in northeast Italy. It's really been a disaster there because of overwhelming the healthcare system. And in New York, we were having troubles there as well. So the idea is to spread this out over a longer period of time. You may have fewer cases, more people may be susceptible, but it will give the healthcare system time to be able to adjust to the large number of cases. The concern here is you flatten the curve, and then you have a risk of resurgence following lifting of interventions. I think there's an excellent chance we'll see more rounds of this virus in the fall and spring over the next year. No one really knows. Maybe it'll go away and stay away forever. But based on other epidemics, such as the 1918 flu, there's a really good chance that you'll have a second peak of infections next year. And then finally, the last thing here is just talking about coronaviruses on surfaces. This study appeared there's several studies. This is not the most recent one from the New England Journal, showing that virus will survive on surfaces for various amounts of time. The only one whether people can get infected from these surfaces, one has to really think about how the mechanics could work. If you're on an airplane and somebody touches the door handle to the bathroom, for example, and then you touch it 5 minutes later, I think that's a way you could get infected if you then touched your face. But on the other hand, if somebody sneezed on a banister and it was 4 days ago and they don't have a huge amount of virus, we wonder how much virus is left, and if any is left, could actually infect someone. We don't know. That's why we're disinfecting everything madly in hospitals and other places where there are groups of people, like nursing homes. One thing that's interesting and important is surgical gloves. One of the reasons that people have to be careful with gloves and masks is that you could well get secretions on them that are infectious, particularly if you're in the hospital. And if you don't take your gloves off properly, if you don't take your mask off properly, you may lose all the effect of having used them in the first place. So we spend time in our hospital teaching people how to actually take gloves off. You would think it's obvious, but it may not be so obvious. So just some of the last things here. Do anti-HIV drugs work? No. Coletra was one of the ones that was bandied about, but the study in the New England Journal showed that it didn't work, and they shouldn't have worked. They're not even that not so effective against the coronavirus proteases. Anti-flu, there's one polymerase drug that people say will work, but it hasn't been in any controlled studies. Susan mentioned this. The virus is not mutating. This is one of the fakes, and that's why it's spreading. There's no evidence that it's mutating. There's lots of changes, but they're not incorporated into the virus that's spreading. The virus is man-made and engineered, and I'm periodically asked about this. Either the U.S. developed it to give to China, or China developed in the Wuhan Institute of Virology. Both of these are false. This virus looks like other bat coronaviruses we've seen. Even the furin domain is found in some coronaviruses. So this is definitely not engineered. And how to get into humans? It's a good question. We think it went into the markets. For a period of time, we thought it was via these pangolins, which can get a disease caused by a virus very similar. But it turns out the virus, even though pangolin coronavirus has almost identity to the receptor binding domain of SARS-CoV-2, the rest of it is not related. So probably not pangolins. The virus will go away when the weather warms up. We hope that's true. And it'll become a seasonal respiratory virus. Well, that's also a possibility. So I'll stop. This is no longer a joke. I heard they stopped selling Corona beer now because of the implication of the virus. So with that, I will stop.
Well, thank you, Stan, for taking the time to give us such a really interesting lecture and so topical. Your knowledge of this is really stands out, and thank you very much. So going to questions, many of our questions have turned on, can I get this lecture? Are these recorded? So we're going to be tweeting out the address to get this. So our Twitter handle is PennCoV, PENNCOV. So watch our Twitter feed for where to find the lectures and lots of other information on the emerging epidemic. So Stan, there are many questions on your interesting lecture. So several people wanted to know about cross protection. What do we know from SARS-1, from MERS? If you're infected with one of those coronaviruses, are you protected from others? Or what about the cold coronaviruses? If you have a cold coronavirus, are you protected from SARS and MERS? Is there any way to judge?
Yeah, I think almost certainly if you're infected with a cold coronavirus, you are not protected either SARS or MERS. There's not really evidence of cross-reactivity. What we don't know for sure is if SARS-1 would protect you somewhat against SARS-2. It's kind of a moot point because there's not that many people who are infected with SARS-CoV-1. So then there probably, some of the studies have shown there is some cross-protection, but it's not complete. So yes, if you were protected with SARS, if you had SARS-CoV, you might be protected to some extent against SARS-CoV-2.
Great, thanks. And on a related note, is there any way to judge for SARS-1 or MERS? If you've had it once, are you protected from subsequent infections or not?
Yeah, this of course is a great question. So, and we don't know the answer to it. Based on studies that we've done and other people have done, I would think that you'd have protection for at least a while. And we know that antibody wanes, but that doesn't say that B cells memory has waned. So you may be re-exposed to it and have a response that protects you. Remember, the goal here, for at least from my way of thinking, is not necessarily to protect everybody against infection, is to make sure nobody gets the severe pneumonia. Because if people walk around with a cold or more severe upper respiratory tract infection that has no mortality, not ideal, but obviously not as bad as people dying from the pneumonia.
So another question centered on defective interfering particles. Many viruses make defective interfering particles that mitigate infection, picornas, many others. What do we know about coronaviruses and defective interfering particles?
Well, we know a lot about defective particles, but whether they're interfering is questionable. It's certainly not like the original studies with VSV, where you could put in these particles and you could see the replication of the wild type strain go drastically down. But you can certainly find these defective particles, which are actually the basis for making replicants. But I don't know of any data that they're actually interfering.
Great, thanks. Let me ask a question. We're all wrestling with the question of why some people get severe illness and others very mild. Might it be the inoculum, just the amount of virus they take in initially? What's known about inoculum and subsequent pathogenesis?
Yeah, so I don't think anything's known about that. Certainly in animal studies, the more virus you give, the worse animals do. And you would think, just off the top of your head, that you would think that having more virus can't be good. So that probably contributes, but I don't think that's a major point. I think that the major points are going to be comorbidities and maybe underlying genetics, which were discussed by Susan. That's a possibility too, that there could be genetic components. But I think that age and underlying comorbidities are the main reason that people get more severe disease.
Thanks. So Una O'Doherty asked, can we use molecular clock kind of thinking, looking at the rate of accumulation of mutations to dial back and identify an accurate time for initiation of the epidemic? What do we know about that?
Yeah, people have done that. That's where they've come up with that mid-November date, maybe November 17th, if I remember correctly, by doing that dialing back. But until we get more information, I don't know how solid it is, but that's been done already. And that's the information we have.
Great, thanks. Several other questions surrounded immunopathology late during disease and treatment with immunosuppressives. And there seems to be a lot of debate about whether there is or isn't a cytokine storm, whether immunosuppressives laid on help or don't help. What do you think about that?
Yeah, so from our experience with other coronaviruses, I think there's probably some sort of cytokine storm. There's papers published showing that you have increased levels of some cytokines like IL-6 and TNF. But I think I've come across other papers now that are saying, well, no, that's not really right. There's just actually a suboptimal immune response. So I think we don't know for sure. Certainly, immunosuppression has to be used. I tried to talk about that a little bit. If you're going to use it, it has to be when virus is mostly cleared, and you'd like to have a biomarker for showing that you actually are having some sort of cytokine storm or excessive cytokine production. Because certainly we learned from both SARS and to a lesser extent with MERS. So in SARS, they treated patients with ribavirin to kill the virus, and then corticosteroids to suppress this exuberant immune response. Unfortunately, ribavirin had no effect on the virus. Corticosteroids resulted in a higher mortality, so it was actually a bad pair. In MERS, they're doing a little more carefully, but the only thing I found from using steroids, which of course are a broad immunosuppressive, is that virus is cleared less quickly. But they haven't found other adverse outcomes.
Wow. So thank you. One last question. What about gender differences? We're hearing there may be differences in outcomes between genders. Is that true? And do you, what's the base?
Yeah, so I think it's an interesting question because when we did some studies with mice and showed that female mice did much better against SARS than after infection with SARS-CoV than male mice did. And we could show that it was definitely male versus female. We could take the females and neutralize estrogen and show that they became then as susceptible as the male mice did to the infection. In people, it's harder because taking MERS as the extreme example, men are around camels, men are often have comorbidities and other issues that may make them more susceptible. So in humans, it's very hard distinguishing environmental factors. China, men smoke, women don't so much. Of course, women are around smoke pots, which also gives them lung disease. But distinguishing environmental and genetics in people is tricky. But in mice, it was clear because it was just the only difference was male versus female. And there was just really a huge difference, more striking than we saw in any human analyses.
Great. Well, really interesting. Thank you so much, Stan, for presenting such an interesting lecture. It was really, really very informative. So I'll clap for everybody.
Okay. Thank you. It's been a pleasure.